Thank you, Madam Chairman. I just want to touch on a couple things specific to my district. I'm a general surgeon. I worked at a VA hospital as a fee-basis physician, and I've also seen patients in my office as a fee, on a fee basis to help the VA out when they couldn't get the services at their facility. My concern, number one, is this whole idea of not being able to manage the spending is a huge issue. But I'm just wondering, is there, you think in your mind, an idea that the cost of the program is inhibiting the VA from sending people to a local facility for their care? I mean, I've got a case here that I'm looking at, and I'm sure my colleagues have many of these cases too, where a guy had Agent Orange-related cancer, and he couldn't get his chemotherapy in his hometown because he was denied the fee-basis care, and he was told, well, you couldn't drive 4 hours and 7 minutes to Detroit and get your chemotherapy in a facility in Michigan, so that you're not geographically inaccessible to a VA facility, and yet it's 12 minutes to his local facility and 4 hours and 7 minutes to Detroit, plus 4 hours and 7 minutes back immediately after his chemotherapy treatment. So is there some sort of a universal rule about who's eligible for, what distance qualifies you as eligible for fee-based care? Because my people don't seem to think that there is, and it's basically up to the local VA facility to decide. And I'm just wondering what the criteria are then for those people to just make that decision. Is it excessive cost? It becomes a detriment because their budget is over. Let me get your perspective in answering that thought that I'm having here.
Sure. Thank you for that question, Ms. Branischek. First of all, I think there's I guess probably VA would be a better panel to answer the
Well, I want to hear from, you must have heard these things
Sure.
before.
So in order to get fee care, there has to be a clinical determination that the care is indeed needed, and whether it can be provided through VA's hierarchy of care. There's a decision process on whether or not the care can be provided within VA, another VA facility that's close by, through DOD or academic affiliate sharing agreements. After that, it's contract care, and then after that, it's fee care. Now, in addition to the clinical determination and availability of services, there's also an eligibility determination whether the veteran is eligible for fee.
Well, what I'm saying is this guy apparently qualifies for all that, except for the only difference is the distance.
Yeah, I understand that, sir. I cannot tell you what kind of a justification was used. I don't know the details of the case, but this is just one example, as I'm sure all the other members on the of the subcommittee has, about the variation of how this delivery, model of delivery is implemented in the field. The NAPA study talks about that, about the wide variation on how the delivery of care is, how care is delivered through fee care. I mean, there's just, that is a signature problem of fee care. What you get at one facility may not necessarily be the same at another facility, to even take into account the geographical access, because geographical access in a rural area cannot be the same geographical access in an urban area or in an area with a high amount of medical resources. So that all has to be flushed out, which it really has not.
Please.
That's a great question. I think it's more VA system driven than patient driven, and I say that from what we've heard from veterans is, where are they involved in the process with whether, if they do have to drive. So the first question we have is, how is the veteran part of the decision on whether they could be fee-based? VA is moving towards a patient-centered strategy. those discussions should happen with the patient. What's the patient want? If they don't have, if they have to go for reoccurring appointments twice a week, and they choose not to do that, or they're elderly and they can't, or they live in geographically inaccessible places. And then the second part is, what recourse does a veteran have in the case that you had pointed out with, if they're not, or, if they're denied to be.
Well, they called me.
Right. Yes, sir.
And I want to get this problem solved, because I know that when I take care of patients, they check me out. I mean, the VA checked me out, make sure I was board certified, and make sure I had the experience to do what I'm doing. And I just don't understand why that doesn't happen in general. Why can't the local facility have been contracted or determined to be able to provide this service and just deal with it? I think the VA needs to have a much more extensive outreach program to its local facilities to be sure that the people are qualified and there's somebody available to do it, and have the fee all figured out in advance. And I mean, I did stuff like that when I worked for the VA. Why doesn't it happen generally? Because to me, this out-of-control cost business, there should not be, because this should all be figured out in advance. So it's very disheartening to me to worry that because of the cost of it, this guy is having to drive 4 hours, because they're worried that it's costing too much. So anyway, I'm out of time. Thanks.
If I may, I would also like to quickly respond to that. I think that VA has said through NVCC one of the primary goals in the first stage of this is to create a fee handbook that everybody gets and everybody sees all the same processes and everything's standardized. I think this is a great opportunity for you to affect change through good oversight of the creation of this handbook. Because why have a handbook if it doesn't solve the problem that you're bringing up? So I would just bring that to your attention.